Good morning, everyone. Good day to all attendants in this meeting, wherever you are. First of all, I would like to thanks to RCR team for inviting me in this very special event, group of friends, colleagues from everywhere. Again, thank you. That's the topic of my talk today, to update 2 years on the Indonesian experience due to the global pandemic of COVID-19. This is the outline of my talk for today. The first wave COVID new cases peak in Indonesia was happened in January 2021 with 14,000 new cases a day. And 6 months later, with the appearance of the new variant Delta, Indonesia hit again by the second new cases peak in July 2021, with the number was 4 times higher than the first, reached 56,000 new cases a day. Nowadays, with a very strong effort in the field of public health, included promotion, different phase of lockdown in different area and time, as well as a massive vaccination, the number of new cases reduced to more than 90% with around 2 to 3,000 new cases a day. Now we are in the rank of 13 of total confirmed case with 4.1 million confirmed case, number 22nd for the new case, and also number 11 for the number of death case globally. Vaccination program in here started in January 2021 with the significant acceleration during the second peak time. So at the time, we are struggling with increased medical services facilities for facing a bulky number of COVID-19 patients and also increasing the capacity of number of vaccine. And nowadays, more than 120 million vaccine were given already as one of the success country for the vaccination program from the target to 108 million. And this is the national vaccination program. These are the comprehensive program from the government done and still real-time evaluating, adjusting, and implementing almost daily by our Minister of Health, including the public campaign, providing the regulation, increasing the preparedness of the medical service in our country. An example of different regulation for different aspects of living, for example, large-scale social restriction, also called the PSBB, and large-scale social restriction transition, and emergency community activities restriction, and also fourth level of community activity restriction, and many more. And also other example for vaccination program in different group of people in the population, elderly, medical employees, kids, etc. And also the regulation in the field of transportation, national recovery program, and also adjusting the ethical regulation for medical practice, education, as well as research during the pandemic time. The latest public health measure and restriction in community activities based on the fluctuation of number of new cases of COVID-19. In Jakarta, as capital of Indonesia, health promotion and public health measure is continued to be increased. We strictly, we call it as the 6M program, clean and healthy lifestyle. And we use also a special app for monitoring public activities and status of vaccination, as well as the PCR swab result and the impact of COVID status to public area activities and also facilities. Now, how is the impact of COVID-19 to oncology services, especially radiation oncology services, that we got the data from the survey that we have done to 45 from 47 radiotherapy centers within the countries. In 100% radiotherapy centers, screening is done mandatory to all patients, both new and patient during irradiation. And 91% have dedicated staff to do those screening in triage station, either doctors, nurses, RTT, or well-trained security. Method of screening can be from interview about the history to contact or previous trip to the red zone area, body temperature, blood test, antigen or PCR test, and more than 50% of the centers did this method. How about the vaccination and PPE? 89% of all radiation oncology have already received at least 2 times vaccination, some already 3 times, and 89% of radiation oncology center have already provided to all personnel within the department with at least 2 doses of vaccination. And 100% of Radiation Oncology Center implement a recommendation of PPE that come from the Indonesian Radiation Oncology from all the employees within the department. This is our last year publication about impact of COVID-19 to the radiation oncology services within the countries, which is in general they were reducing the number of new cases during this pandemic time. At the first wave of COVID-19, 82% of radiation oncology centers reported the reduce in average of 21% in new cases, new radiotherapy cases, and 68% of centers reported also the reduced number of in average 17 fractionation daily. At the second wave, there were 89% reported decreased number of new radiotherapy cases. It is higher than the first at the first wave. With the 71% center reported reduced number of daily fractionated. It is also higher than the first wave of COVID pandemic in our country. You can see from the graph from May, June, and July, the number of new patient maximum reduced is in July. It is in line with the peak of COVID-19 new cases. Just to compare radiation oncology service in the first and the second wave of COVID pandemic in our country. 64% of radiotherapy center reported reducing the working hour, especially in the second wave, due to a lot of medical staff got infected, rotational working shift, as well as the total number of patients is reduced significantly. 400 patients reported got infected by COVID-19 during the irradiation time. And in this case, the irradiation is postponed and the patients are sent to the COVID center in the hospitals. So it is not surprised that as well as that 42% of radiation oncology employees in Indonesia got infected from COVID-19. So we can say that both cancer patients as well as radiation oncology employees are vulnerable to get infected from COVID-19. Even 3 centers have to treat the COVID-19 positive patient due to one and other things. For example, in our hospital. 51% of radiation oncology centers implement the hypofractionation schedule to their patient, but only 3 of the centers reduce the number of brachytherapy fraction. For example, in our center, we reduce from 3 fraction to 2 fraction. Change of demographic happen in 11% of radiation oncology center, even mostly still the same demographic as usual. And how about the education and training program? For the selection or recruitment process, we do in hybrid, both online and offline. How about the curriculum? No change in curriculum. Modification in lecture with combination both online and offline. Research is not postponed. Some a bit delay happen. Hand-on workshop it is reduced in surgical oncology, but no change in radiation oncology. Number of cases decreased in 5 to 20%. Reduction in target case in surgical oncology, but not in radiation oncology. Working in network hospital, it is happened in surgical oncology, but not in radiation oncology. Evaluation is no change in verification of competence, workplace-based assessment, or so-called the case-based discussion or direct observe procedural skills, mini CX portfolio, and also OSG written test also happen, run as usual. Increased number of postponed graduated student is not happen in surgical oncology, but it is happen in radiation oncology. PPE is provided for all students for free. Reduction in working hours with only 40 to 50 hours per week. All students are facilitated with COVID-19 diagnostic and treatment for free if necessary. And for surgical oncology residents, they have to go to the volunteer in COVID-19 ward, but it is not for radiation oncology residents. Now we are moving to part 3, strengths and challenges experienced in Indonesia. The main challenges are how we can end the COVID-19 pandemic in Indonesia and how we can adapt with the new situation. Even so, the government has put our immediate priority to mitigate and contain the impact of pandemic in helping people to survive and to live with the pandemic. In general, the government has implemented several policies suppressing virus and anticipating new cases by enforcing border controls, strict health protocols, and carrying out lockdown. The second is expanding testing, guaranteeing and treatment capacity and health protocols, procure medicine and conduct research, increase capacity and service in health sector, and provide the citizen with access to vaccine. To maintain livelihood, the government has provided support to less fortunate communities among others by lowering electricity tariff, relaxing taxes, easing credit, creating new jobs, providing no work compensation, as well as providing daily support. Priority for job creation, assistance, and upskill, maintaining the availability of liquidity and financial system safely net, public infrastructure investment, and to fund all the above program to face possible future situation. The government has allocated a fiscal package amounting to US dollar 46.7 billion and support the national economic recovery in 2021. Focusing on the healthcare, our professor has been designing a zoning system to limit the COVID-19 infection rate in the hospital in order to protect the staff and the patient. And our society, since the beginning of COVID-19 pandemic, has launched several guidelines in terms of facilities, staff management, to use the appropriate PPE, and the guidelines is still implemented until now. It is how our staff use appropriate PPE in patient handling with positive COVID-19. The guideline has also included patient management, such as patient screening and triage, the use of face shield and mask for everyone in the department, rapid test and PCR test before the treatment, modified stratification, and the use of telemedicine. This is currently how it looks in our department. During the peak of COVID-19 pandemic in Indonesia, our society has modified stratification to treat patients in our facility. However, in line with the decline in the number of the COVID-19 cases in Indonesia, these guidelines is even more relaxed. And the important thing is we have been using telemedicine a lot since the beginning of the pandemic and until now. We use it for teleconsultation between the patient and the doctors who still work from home. We use telemedicine for virtual multidiscipline meeting, both local, national, as well as international. And also the purchase of training and education, such as a daily case report, chart round, etc. And examination. Although all this is getting loose need as a case decline. IRAS have been conducting webinar series almost every month now with various topics and speakers, national and international. The target participation are not only from the medical professional but also from the public, patient survivor group, and also family. Thank you very much for your kind attention.